Hormone therapy is licensed to manage symptoms in the menopause. As we get older, go through the perimenopause and menopause, there's a drop in estrogen, progesterone, and testosterone. So it's simply giving it back to those women who need it. The safety profile lies with the body-identical hormones, where we use the estrogen, and the evidence shows that it actually reduces the risk. So hormone therapy, hormone replacement therapy, menopause hormone therapy. Quite a few terms out there. We're going to stick with hormone therapy. What is it? In my mind, it's simply giving back what the body needs. As we get older, go through the perimenopause and menopause, there's a drop in estrogen, progesterone, and testosterone. So it's simply giving it back to those women who need it. There are about 25% of women who either have no symptoms or barely any symptoms of the menopause, and they get through it and they come out on the other end and they go, I feel absolutely fine. But for the majority of women, it can be very difficult and debilitating. So how do we give these hormones back when it's right for that woman at that point in time? Hormone therapy is licensed to manage symptoms in the menopause. How do we give it? There are various forms. You can use it as oral pills or capsules, through the skin, as a gel or a patch, and also in the form of a Mirena coil, which some women may or may not have heard of. It's important to know about this because hormone therapy is actually very low dosing, so it doesn't work as contraception. Yes, you can still get pregnant in the perimenopause when you have a period. Let's go through each one. Estrogen, we look at estradiol, which is the body's own natural hormone. It can be given in the form of a pill, a gel, or a patch. Ideally, we stick to what's called transdermal, meaning through the skin, either as a gel or a patch, from a safety profile viewpoint, especially when it comes to increasing risk of blood clots through the older oral synthetic estrogens. Progesterone, we use Bioidentical, which we use as Utrogestan, for example, and this can be taken in the form of a capsule, orally or vaginally, depending on tolerance. And yes, I appreciate it's taken orally, but it tends to get dispersed into the body, so that risk profile is also less. Testosterone, we don't talk enough about testosterone. It's technically licensed for a very low sex drive condition called HSDD, and that's where we have the evidence for at the moment, but there's a lot of research being done because of the additional benefits when it comes to the genitourinary syndrome of the menopause, energy levels, muscle mass, and the impact and effect on the brain. This can be used as a gel. In certain parts of the world, they can be inserted as pellets as well. There's only one testosterone that's licensed for women. It's called Androfemi 1, and it's produced in Australia. So accessibility globally is not as easy as some of the other, the estrogen and the progesterone. If a woman has their womb in place, they need to have the progesterone component to protect the lining of the womb. That's what the evidence says now, and that's what we follow. Progesterone is also a calming hormone, so it can help from a sleep point of view, from a mood point of view, and that coupled with the estrogen is what we tend to use initially for most women. And then the testosterone can be added on depending on their symptoms and if it's indicated or not. If a woman has had their womb removed, so a hysterectomy, there is no need to use the progesterone to protect the lining of the womb. And this is where estrogen plays the important part to manage the symptoms. It also can be used earlier, depending on when the hysterectomy is done, And this is where the prevention piece plays a part. So in premature ovarian insufficiency, or if a hysterectomy is done at a young age, especially under the age of 40, where we use the estrogen, and the evidence shows that it actually reduces the risk of heart disease. So it can be quite complex finding what works together in combination for each woman, because it is individualized. So I look at it as, yes, we have a lot of evidence, very much a scientific approach, but there's also quite an art to listening, to hearing women, because at the end of the day, they do know themselves better than anyone else. So the prescribing of hormone therapy, when indicated, should be done in conjunction with the conversation with that individual woman. It's a very clinical assessment when we look at monitoring hormone therapy. We use a menopause symptom questionnaire, and it's about sitting and listening and hearing what the woman has to say. There are times where, based on the symptoms, you can see that more estrogen is needed, sometimes more progesterone, and other times testosterone, or a combination of 2 or 3. It's about reassessing and monitoring, but also giving things time. The beauty of hormone therapy is the first 3 to 6 months is simply a trial. When you stop hormone therapy, within a couple of days, it's out of your system. So it's not something that sits there and can cause long-term impact or damage. And that's important to know. So progesterone intolerance, yes, we see it. At this point in time, we need to use the progesterone to protect the lining of the womb. But it's also about the calming effect it has. There are various ways of using progesterones. You can use it orally, vaginally. There are creams that can be used as well. But not forgetting the Mirena coil, which sits very locally in the womb to protect the lining of the womb, but also works as contraception. So it's having the discussion at an individual level to balance the side effects, any risks versus benefits, and finding the right progesterone at the right dose in the right form for that woman as an individual. Micronized progesterone is a body-identical hormone. So it's as close to the body's own hormones. It also gets disseminated in the body. And yes, if there was a choice in progesterone, it would be the body-identical progesterones compared to the older synthetic progesterone, which when taken orally can increase the risk of blood clots because it has to go through the clotting cascade in the body, so through the liver and then in the gut. Yes, there's a lot of confusion about versions of hormone therapy and what's actually available in different parts of the world. The safety profile lies with the body-identical hormones because it's as close to the body's hormones and estrogen given through the skin and the micronized progesterone, plus or minus the Mirena coil, and then the testosterone through the skin. These are body-identical hormones. Bioidentical hormones, on compounded hormones, this is where lots of blood tests are needed to compound and create a formulation for you as an individual. Unfortunately, this is not FDA approved because it's very hard to approve something that is so individualized. So it is used in certain parts of the world, but as per the guidelines and the research that I follow, it's not something I would use and be able to recommend. I think there is definitely a lot of confusion and we need to make it clear as to what is available and the evidence base that we have to utilize that treatment. In America, for example, and within the functional space, there's a lot more use of the bioidentical compounded hormones, and it possibly has its place. I have patients who have been on it a long time and it works for them. But it's also looking at the latest evidence that's available and making sure that patients receive the best care available to them based on that evidence. So the older hormones, especially used as part of the women's health study 22 years ago, were synthetic, combined oral hormones. What we have available to us now has evolved considerably, and this is the body-identical hormone. So through the skin, either in the form of a patch or a gel, the micronized progesterones, and that is where the current safety profile lies. So prescribing-wise, that is what we tend to prescribe in the majority of women. There's still the option of combined oral preparations, and this is where we have a conversation with the individual, looking at the risk versus benefits, and also what's easier for them to use and take. And it's part of the conversation that's had to make sure that it's individualized for that patient. So local vaginal estrogen, so we use Vagifem for example, is a little tablet that goes up the vagina, and it's a very low dose of estrogen, and it stays within that local area. So a lot of the times we tend to use that when there is dryness and symptoms associated with the genitourinary syndrome of the menopause. So because it's local and it gets absorbed and it stays in that area, it doesn't go to the rest of the body. So it's a very local treatment. When we look at contraception in the perimenopause and menopause, it's important to have contraception in place, especially in the perimenopause, because the risk of pregnancy is still present. Now, there are various options for contraception. Ideally, we look at longer-acting contraceptions, but it depends on what the woman wants, the patient wants, as an individual. But it's making it clear that when we look at hormone therapy or start hormone therapy, other than if they have the Mirena coil in place, so this is the little contraceptive coil that sits in the womb, producing local progesterone to protect the lining of the womb. It's the only long-acting contraception that can be used as part of hormone therapy. So it's the progesterone component as part of hormone therapy. If we're using anything else, we can look at alternative contraceptive options, including the various pill options, the patch options, and other long-acting contraceptions, so the implant or the injection. So if you're on the combined oral contraceptive pill, the estrogen and progesterone component in here is synthetic. So it does actually play a part in reducing our own natural hormones. Yes, it's licensed if there are no contraindications until the age of 50. And there are some women who are on it. It works for them. They've not had any side effects or any problems with it, and they're keen to continue it. And at times, it's managed any perimenopause symptoms to a certain extent. But again, this is very individual. Whilst on contraception, when the perimenopause symptoms start to affect quality of life and day-to-day activity, then we need to look at hormone therapy, but in its most natural form. So it's looking at contraception with hormone therapy at an individual level, and looking at the safest way to do both.